So most of you attending are probably already members of Dying with Dignity Canada, but I'll just mention that our mission is through advocacy, public education, and personal support. Dying with Dignity Canada ensures Canadians have access to quality end-of-life choice and care. And we try to really represent the 86% of Canadians who supported the Supreme Court of Canada's decision around medical assistance in dying. We have chapters across the country and 2 active chapters here in Alberta. The Edmonton and Calgary chapter have been collaborating ever since, really ever since their inception, but more so since going digital due to COVID. And so I really appreciate all the support that the Calgary chapter has lent us. And the Calgary chapter actually recommended our speaker tonight. So thanks so much to our friends down at the Calgary chapter. If you want to get involved, our email here in Edmonton is edmonton@dyingwithdignity.ca. And when it's not a COVID year, we were hosting speakers and film viewings and workshops. And more recently, we've just been doing webinars with really great speakers every couple months. So I hope you'll reach out and get involved if you're interested. I'll just mention too, we do have a summer webinar series coming up through Dying with Dignity Canada's national office. So June 30th, there is a regional spotlight on death and dying in Eastern Canada. On July 21st, there is a spotlight on nurse practitioners, which is appropriate for tonight's presentation. And August 26th, there is a webinar on reflecting on life and death, legacy projects and art at the end of life. So check out dyingwithdignity.ca if you are interested in registering for any of these summer webinars. And we'll just go on to our guest speaker, who I was just chatting with and telling her I think she's so cool. So I'm excited to jump into the conversation tonight. Reanne has more than 20 years experience in cancer care, is the current president of the Canadian Association of Nurses in Oncology, and has special interest in symptom management, sexual health and cancer, the integration of palliative care in oncology, and medical assistance in dying. So thank you so much for joining us, Reanne.
Well, thanks so much for the invite. I'll just introduce my co-presenter here, Jasper, and hopefully he'll be quiet for the presentation.
Perfect.
And I'll switch over here to share my screen.
Great.
As well.
And I should mention, we're also joined, of course, by Carl, who is a co-leader of the Edmonton chapter, who will help facilitate some of the conversation tonight. So thanks as well, Carl, for joining us.
And I've put my email address on the screen. I'm happy to answer questions if people have questions that they don't feel comfortable asking during the presentation this evening, or if you have questions about any of the other topics that I am involved with as well.
That's great. Thanks for sharing that.
Yeah, of course. So a brief conflict of interest. I have received some funding for my PhD work and research, but no financial relationships with any medical or pharmaceutical companies or medical supply companies. So I think everyone in this group is probably well versed and familiar with the timeline of the Maiden legislation in Canada. And interestingly enough, I don't know if everyone knows this, but it's exactly 5 years to the day today since Bill C-14 became law. So that's kind of serendipitous that we're talking about this evening. And then, of course, the recent changes, the revised legislation with Bill C-7. And I, I'm a person who likes stories, and I'll tell a few stories this evening. But for me, learning about the history of Maiden Canada and some of the people that were very involved in influencing the legislation changes, I think just keeping in mind their stories and honoring their stories is always so important. Starting way back in the early 90s with Sue Rodriguez. And then, of course, this is Kay Carter, and she's the one who really is responsible in many ways for the legislation changing. We'll talk a little bit probably about the changes to the legislation, the challenge to Bill C-14. And really, I think this was interesting. And for me, is someone who's done MAID assessments or eligibility assessments for quite some time now, I could really appreciate the concerns that were raised with this challenge. And Audrey's amendment as well. And certainly as an assessor, I had seen this often and I was always very concerned. So of course, this waiver of final consent, it broke my heart hearing her story. So she had metastatic breast cancer with brain metastases, and her concern was that she was going to lose capacity before she would be able to consent to MAID. And so she elected to undergo MAID much sooner than she would have preferred to, because she feared losing capacity. And that seemed quite unfair. And unfortunately, I have seen this and heard of this over the years as well, that people were so worried about losing capacity that they potentially lost good quality time with their family and loved ones. So, she said had this late stage consent been abolished, she would have taken her life one day at a time. And certainly now that has been abolished, I've seen people since the legislation has changed. And I can think of one patient that I assessed on St. Patrick's Day, and she is doing just this, taking it a day at a time. She had metastatic pancreatic cancer and was, very adamant initially that she wanted to undergo MAID, but she's now quite happy with her quality of life. And I'll tell you a little bit more about her story a little bit later on. And so, so thanks to this beautiful person, we now have Audrey's amendment and this waiver of final consent. And just a point of clarification, this is for people whose deaths are reasonably foreseeable. This does not apply to non-reasonably foreseeable deaths. And this is the Department of Justice infographic that was released, just kind of highlighting some of the changes with Bill C7. So the eligibility criteria still, there needs to be a grievous and irremediable medical condition. What's changed here is now it doesn't say incurable. There's still, I think, a little bit of quite a bit of subjectivity with this grievous and irremediable component. And the legislation gets into this a little bit more in terms of definition of what is meant by grievous and irremediable. And it used to be that somebody would only qualify if their natural death was reasonably foreseeable. And, I had issue with this because there's the qualifier, I should say, the natural death. So, if somebody has such grievous and irremediable suffering, it's possible that they might want to take their own lives. And that's, in that circumstance, I would say that their death is reasonably foreseeable. It's just this natural piece that was the issue. And so now we have a second track for people whose deaths are not, whose natural deaths are not reasonably foreseeable. They can still be considered eligible for MAID. The criteria is, the rest of the criteria are the same, but the process is somewhat different, that there is 90 days from time of assessment to time of provision, which is much shorter for people whose deaths are deemed reasonably foreseeable. And so, we still have all the safeguards in place, which is really important. And then this waiver of final consent is no longer required for people. People do not need to provide that final consent if their deaths are reasonably foreseeable. That's not permitted if somebody's death is not considered reasonably foreseeable. So again, just to reiterate that, so the natural death does not need to be reasonably foreseeable. And now there's, as I said, this two-track approach, which again, we were discussing prior to the start of the webinar. Alberta Health Services, I don't feel that their explanations and their information on the website has been appropriately updated yet. But I'm told it's going to be updated sometime in the foreseeable future, reasonably foreseeable, hopefully. At any rate, Alberta Justice and Health Canada have this information on their website, and Death with Dignity Canada also does a very good job at outlining the changes that have been put into place because of Bill C7. And so we do see that these safeguards are still in place. We do see, new and strengthened safeguards for people whose deaths are not reasonably foreseeable. At this point, there have not been any changes to allow people suffering solely from mental illness to undergo MAID. And that there's a temporary, tabling of this until 2023 with lots of discussions going forward. And I've been part of the Canadian Nurses Association, has convened numerous meetings to talk about what nurses feel should be important, both prior to Bill C7, as well as now what's going to be happening with mental illness. And you know, the government is looking to different professional organizations to seek input on what we feel would be important to consider. And yes, this waiver of final consent, as I've already mentioned. And so just briefly, because I want this to be more of a discussion, so I'm going to burn through these slides very quickly. Many of you have probably seen the final report, or the first annual report, I should say, that came out in 2019. And I'll just zip through a couple of these numbers really quickly. So total reported MAID deaths up to 2019. And I just saw that, I believe it was last week, the most recent numbers were published, and it's just around, I believe, 7,600 in 2020. So that represents a jump of nearly 17% from 2019 to 2020. And again, when you see those jumps in the numbers, it always makes me wonder why there's been a jump. Is there something we're missing in terms of the care we're providing to people? 2020 was a difficult year for sure, especially for people in long-term care homes and things like that. But what is behind that jump? And now as assessors and providers, we're required to report a lot more information than we were in the past related to what that underlying reason or reasons were for the person requesting MAID. And so it'll be interesting to see what drove the requests in 2020. You know, this may just be a natural progression as people become more and more aware of MAID. We can expect to see an increase in MAID deaths overall anyway. But is there something else that we're missing? So I think this reporting, that was one of the questions that somebody put forth. I think the reporting is really important. We need to understand what's happening, what's driving the requests, and what's, you know, is there something that we're missing as a healthcare community and a society overall? Are we missing some key piece that we could be fixing so that, you know, not as many people are requesting MAID? And to be clear, you know, obviously, I think you get the sense probably that I'm very supportive of MAID. My caution is always that I don't want people to request and undergo MAID if there's a reason or another way that we might be able to alleviate their suffering, because MAID, of course, is a final choice. And so just looking across the country, you know, this is percentage of total deaths. So I think, again, when people get concerned about MAID deaths increasing dramatically, the national average is that MAID represents about 2% of all deaths. So it's still very tiny in terms of numbers. And you can see some fluctuation here. BC has, you know, higher numbers, perhaps partly because of their, you know, philosophy overall and things. They've been involved very much in the news and things. And Quebec as well. I mean, their legislation is somewhat different there. And I think that they were a bit ahead of the rest of the country in terms of their thinking on assisted death. And then the reasons, and again, this is probably not super surprising to any of you joining this presentation. So cancer represents the majority of conditions, I guess, or underlying medical condition that somebody is requesting MAID for, and then respiratory, neurological, so things like ALS, cardiovascular, multiple comorbidities, and I've certainly seen a number of people that would fit this category, but cancer representing by far the majority of underlying medical conditions. And then by age, again, also not surprising, because we're looking at when cancer peaks in terms of, you know, when people are getting cancer. And so this is congruent with that. And, you know, I've seen some people and assessed some people who are, you know, in their 20s and 30s for sure, that have undergone MAID, but not surprising, just given the distribution of some of the underlying medical conditions and associations with age. To me, this was really interesting, the report that came out. So again, we started collecting this data in 2018. Prior to 2018, as an assessor, I wasn't even required to complete the form, didn't even have a section to provide information as to what the person's reason was for requesting MAID. Now there's a section on the form that you can check off as many reasons as apply, and you can include other reasons if the reasons aren't listed. And then also this collecting of data pertaining to palliative care and disability support services. And so I think this is interesting. 82% of assessors, I suppose, reported that the person had received palliative care services. We don't know the quality of the palliative care. We don't know much more about the palliative care other than just who received it. So you can see here that many of the people who received palliative care, 40% of them received it only for a month or less. And ideally, when we're providing palliative care, we want to be providing it for 3+ months for it to really be optimally beneficial. And so again, it'd be nice to have more information on these people, the people who didn't receive palliative care services. Was that because they didn't need it? Maybe they weren't aware of it. Maybe they couldn't access it because they lived rurally or remotely, but what were the reasons why? We don't know that. And so I would hope that going forward, we'll be able to collect more information, or even this would represent a very good area for research to explore this further. Similarly with disability services as well. The majority of people are reportedly receiving disability support services. And so that's good news. But it would be nice to have more qualitative data to kind of complement or fill this out. And deaths by setting, I think this is also probably not surprising that, quite a few of the deaths are occurring either in hospital or in a private residence. Palliative care facility or hospice, that's another setting as well. And then residential facility, long-term care, those kinds of things. Again, a lot of people, when I talk to them, it's their preference. They would prefer to be at home for MAID, and then there can be some reasons why that doesn't happen. And to me, again, you're going to hear me really pushing palliative care this evening. But I think, again, if we had sufficient palliative home care available to people in Canada, that many of them would be able to remain at home and they wouldn't pass away in hospital. And we know that, more than 50% of people in Canada do pass away in hospital in spite of their wishes. And previous survey data has shown us that most Canadians say that they would prefer to die at home. In reality, that's not happening. And part of that, I think, is just this huge lack of resources and supports in terms of palliative home care and keeping people at home as long as they wish to be at home. And so again, this really interesting information about the reasons compelling patient requests for MAID. And so people could select more than one reason when filling out this form. And, I think a lot of people would jump to the assumption that people consider MAID or undergo MAID because they're experiencing intractable symptoms, physical symptoms, so pain or other types of physical symptoms. In reality, that's not really what's driving most people's requests for MAID. Pardon me, we do have on this slide inadequate control of pain or concern about it. In my experience, it's mostly been concern that people are really worried about pain becoming an issue and their quality of life being significantly impaired because pain has become an issue and it can't be controlled. But really symptom control, it has not been a huge driver of the requests and the people that I've seen. The worry about symptom issues definitely has been a concern. But what's more difficult, I think, for us in the healthcare system to fix or to help patients with is this loss of ability to engage in meaningful life activities and the loss of ability to perform activities of daily living. So those things are harder to fix. We have so many medications and so many different things that we can use to manage symptoms, but trying to help somebody engage in meaningful life activities if they're confined to a bed or chair for the majority of their waking hours, that's exceedingly difficult. There's no quick fix for that. And so also, the perceived burden on family, friends, or caregivers, this again makes a very compelling case for the need for home care. If we had 24/7 home care support, this burden would be alleviated for many people. And then again, too, we'd have, more ability to reassure people that we'd have somebody there for 24-hour symptom control should they need it, if they wish to remain at home. So again, I think tracking this data, it's very, very important so that we can look to find ways to intervene so that people are not forced to consider MAID if they really don't necessarily wish to undergo MAID. I don't know why I included this one. Oh, I think it's just showing the number of people who requested MAID versus the number who actually underwent MAID. And so, you know, some of them had been ineligible. Some requests have been withdrawn. And I've seen that as well, where people have said, you know what, I don't really want to pursue MAID right now. I just want it as an option down the road, just in case. And then in some cases, as you can see in Alberta, about 20% of people who requested MAID died before they were able to undergo MAID. And I'm hoping now with this waiver of final consent and some of the other changes that this hopefully won't be as much of an issue going forward. And so reasons for ineligibility. And again, I think here is where we see some of these issues that will hopefully be less of a concern going forward now that we've taken out this reasonable foreseeability, and then not having a serious and incurable illness, disease, or disability. So this incurable part has now been removed as well. So, you know, some of the other things may still be, you know, persistent reasons why somebody wouldn't qualify. So the capacity issue, consent, you know, those ones would still be concerns potentially, just maybe not that capacity right at the very end, which would be not an issue if they were able to waive that final consent. Just to make that case, I don't, you know, again, it'd be nice to have some qualifying information here, not experiencing suffering that is intolerable to them. I'd like to know a little bit more about that. So it'd be great to be able to interview people, and maybe the government will consider doing that in the future. So again, you know, reasons why people have withdrawn their MAID requests, they changed their mind, palliative measures are sufficient. So again, making this case for palliative care, withdrawing immediately before MAID. And I have a patient right now that I had seen, the same one back in March. She twice has had dates for provision, and twice she's canceled those. The family members who do not support MAID is going to be a tricky one. But again, I think part of this is falling to us in the healthcare system as well as society overall, that we need to be talking about this more. We need to be educating people more on death and dying overall, but also on MAID. And, you know, looking briefly at the Alberta numbers, and again, this is probably nothing super surprising to anybody here. But again, the major drivers in terms of health conditions, cancer, MS, ALS, lung disease. I watch these numbers too all the time to make sure there's not huge discrepancy in terms of geographic reason, because if we start to see the average age of people, and initially when we were reporting this data, or this data was being reported, there was huge discrepancy with people in the north being much younger than people in other zones. So to me, that again says, is there a need there that we're not meeting? Now it's relatively consistent. So central zone, they're a little bit older overall. Again, the numbers aren't huge in Alberta to make any significant conclusions here, but definitely an area to keep an eye on for sure. So just to say that, you know, our data is, or the data is similar to what's been reported in other jurisdictions. Most people, so this was a paper published in 2019 about what's happening in Oregon and Washington. And in Oregon, assisted death has been legal since 1997. And so they are the state that has probably the most data. And incidentally, I happened to be presenting at the American Society of Clinical Oncology's Palliative Care Symposium in 2016, putting up my poster, and this gentleman behind me asked me for assistance to put up his poster, and it was Charles Blanky, who's really been one of the physicians in the States that has done the most work, I would say, on assisted death. And so he and I had many interesting discussions throughout the conference, but I found it interesting as well that the reasons in the States, and particularly in Oregon, for people requesting MAID or assisted death were not pain or symptom. You can see 25% of people were requesting assisted death because of poor pain control. But the majority of reasons were loss of autonomy, can't participate in enjoyable activities, loss of dignity. Those are things that are harder to fix. So when I'm seeing people, and, you know, I'll see somebody who their whole lives, they've been very active, you know, physically active, even in their 70s and 80s. And then all of a sudden they're hit with a cancer diagnosis and they're stuck in their bed and they can't be physically active. They can't go to the mountains anymore. That's harder for us to fix. pain and symptoms, we have many, many meds and drugs and options in terms of fixing those things. But autonomy, again, that's a challenging one. And helping people participate in enjoyable activities, helping them find joy, that's very difficult comparatively. So my first awareness of MAID, I'll move now into some of the questions that people have asked. So I've had informal discussions with my family over the years. So they're very independent, very active people, my parents especially. And we've already talked about this long before it was a legal thing or a legal option in Canada. And then when the court ruling was announced, I learned as much as I could about MAID, because as an oncology clinician, as a palliative care clinician, I want to know all the options available to my patients that might help alleviate their suffering. As I mentioned, I met Dr. Charles Blanky in 2016 and had a lot of discussions with him. And then it was either it was early 2018 that the MAID care team in Alberta asked me to assess a patient for eligibility for MAID. It was a patient I was seeing in the context of being his palliative care consultant. He was a patient in hospital. And at first I thought, oh my gosh, no, I don't know if I'm allowed to do this, because you may have heard that there's been some resistance or opposition, at least in Alberta, for MAID to be associated with the palliative care team. I think there was initial concern that palliative care clinicians didn't want the general public to think that that was what we did, that we were the MAID team. They wanted to keep the two separate. It's different in other provinces. It's different in other jurisdictions. I personally don't have an issue with it, but I wasn't sure if I'd be allowed to do this. I was working that day in my role as a palliative care consultant, so I wasn't sure if my boss would let me do this. So I talked both to the medical director of palliative care as well as my direct supervisor, and they both said 100%, if you want to do this, it's absolutely fine. And in fact, on our team, we have some physicians and clinicians who are providers as well. And 100% you have our full support. And I was confused because I'd never heard anybody else on our team talk about either assessing or providing. So that, again, there's kind of a bit of stigma there, I think, still. And so, yeah, ever since then, I continue to provide assessments. I have not yet participated in provision, but I've been speaking with the MAID team about that as well. And I'm interested in moving into that role as well. And to me, my experience as a palliative care clinician really aligns well, I think, philosophically and otherwise with assessing people's eligibility, because I feel that as palliative care clinicians, we at least have the knowledge and awareness of so many different options to help patients in terms of alleviating their suffering and helping to improve their quality of life. So if I can assess them and say, well, have you thought of X, Y, and Z, or what have you tried? I'm in a really good position, I feel personally, to be able to help them with their suffering. And so to me, it's a really good fit. And so, yeah, this is another question. I think this is a great question. Has MAID allowed for more conversations on death and dying? I think, yes, it's still small scale and we're still very much a death denying culture. And even now in the context of COVID, I think we're hearing more and more about death and dying. And, I was hopeful that that might push the conversation a little bit more into the mainstream as well. But there still is very much this complete avoidance of talking about death and dying. And I was mentioning to Brad earlier that, in my career, I've somehow have ended up with sexual health and palliative care as my kind of core areas of expertise and interest. And the, death and sex are kind of the two ultimate taboos in our society. And, there's stigma associated with both, for sure, with even the term palliative care. I just did a qualitative study where I interviewed 26 patients, family members, and clinicians in the bone marrow transplant area. And as soon as I mentioned palliative care, almost all of them, including the doctors and nurses, associate palliative care with end of life or death. And so very much there is still a stigma associated with all of these things. It was interesting because last May, I think it was, the Alberta Cancer Foundation published, they have a magazine called Leap that comes out, I believe it's monthly or quarterly, I'm not sure. And they did an issue on stigma, cancer and stigma. And they interviewed me for two of the articles. One was about palliative care, one was about sex. And again, there still very much is that stigma associated with both sex and death, and certainly also with MAID. And there's been some studies, and I'll share them in a minute, that talk about, even people undergoing MAID, sometimes they're not readily forthcoming with that information to their friends and family for fear of what the reaction might be. This was also kind of in the early days, and kind of answers a few questions that were submitted. So again, to me, I really felt like, and I still feel like, assisted death should be an option. I think it's a very important option for many people. At the same time, I also feel like we are not fully supporting end-of-life care in Canada to the extent that we should be. This patient, the fictional, I changed it, and it was actually kind of a combination of a few patients and things for this article. But the person that kind of inspired me to write this was somebody I'd seen as in my role as a palliative care consultant, and she had a type of leukemia. She'd undergone a stem cell transplant for that, and she'd been in hospital ever since her transplant had happened. So in and out, but mostly in, for about 6 months. And I believe she was in her early 50s, and she requested assisted death. She was determined to be ineligible. I didn't do her assessment. And this, I think, raises a really key point of the person doing the assessment really ought to have some underlying knowledge of the person's medical condition or conditions. Because I knew, having worked in the bone marrow transplant program for over 10 years, that even though this person's leukemia was in remission, she was experiencing so many treatment-related complications that those were likely going to be the cause of her death. And she ultimately elected to stop some of those treatments, and she died within a few days. And so even though she was denied death by MAID, which was her wish, she ended up passing away very shortly after her request had been submitted. And again, I would have approved her because I understood her medical condition and I understood what her prognosis was. But I think this is something really important going forward. And that's something that has been submitted in the context of mental health as the sole underlying medical condition, that we ought to have experts involved in the assessment. I guess the other end of that, that's a bit worrisome, is that will that end up being a barrier for people if they can't access that expert assessment as part of their assessments for eligibility? Will that slow down their process? Will it even impede or will they ultimately be denied MAID because they don't have access to these experts in some parts of Canada? Another question that was submitted, nurses and NPs education on death and dying. It's really not great. It's really not great. I think back to my own, and that was a long time ago, of course, so hopefully things have improved. And certainly there's a paper that I read that said 96% of nursing schools in Canada have some content on death and dying. I believe the average was about 24 hours of, kind of classroom learning and 36 of clinical practice, 36 hours of clinical practice. That's scratching the surface, really. My feeling is that there should be embedded courses. It should be mandatory for all healthcare professionals to take these courses in their undergraduate and graduate programs. So the National Framework on Palliative Care in Canada that was published in December 2018 says that there should be, mandatory training in healthcare professionals' education. Just this hasn't been publicly released yet, so I might get my hands slapped for this. But this is the Canadian Partnership Against Cancer in conjunction with Health Canada has come up with this Canadian Interdisciplinary Palliative Care Competency Framework, which is to guide educators for all different disciplines who might provide palliative care. It's an excellent document. And I think that, this is an actionable piece that's come out of the National Framework on Palliative Care. And so, yeah, just like speaking directly about what some of the goals would be in terms of training for healthcare providers. This is the article I was referring to that talks about student nurses and the lack of education on death and dying in nursing school curricula. And also, I would say, and this won't be surprising, but definitely a lack of education on medical assistance in dying in medical and nursing school curricula right now. And so these students, and this was a small qualitative study, some of their recommendations were that there should be core content embedded in the curricula and that there should be opportunities for students to talk about this and work through their feelings. You can imagine somebody starting in their position and kind of, just being taken by surprise and not really understanding even how they feel about MAID. And that if that person isn't adequately prepared, then it's going to be very difficult for them to support the patient and family. And even doing some role playing and simulation to talk about these issues pertaining to MAID. Oh, this is out of order. I'm sorry. This is that framework again, the interdisciplinary framework of CPAC. So they've got some core competencies that they're hoping to see the health disciplines adopt. And for nursing, this concept of a palliative approach to care, and just having some of the basic competencies that all nurses should have, irrespective of their practice settings, because they will all encounter patients who are potentially dying or experiencing suffering with serious medical conditions. The impact of MAID on the grieving process, I think, is also really interesting. And we don't have a lot of Canadian data yet. This is a paper that was published a couple of years ago. But if we look to other jurisdictions, many of those studies would suggest that assisted death tends to lead to better bereavement outcomes for family members. Where I think it becomes more difficult is if there's discordance within the family. So if the family doesn't agree or doesn't support the person who chooses an assisted death, then the grieving process can be a little bit more complicated. And that's something when I do my assessments, I always ask, how do your family members feel about this? Is anybody opposed to this? And that's not going to change my assessment at all. It's just going to, flag it for me to say, we might want to look at providing more psychosocial support to this family and provide more information to the person who perhaps is opposed. And trying to support them so that bereavement isn't as complicated going forward. So, a lot of these papers are quite interesting, and I've put the references. I'm happy to send people the articles as well, because some of the quotes, and again, they're qualitative, so not huge numbers. This one, it was 18 support people for patients seeking MAID, but the quotes were quite interesting. So, people, here's one quote: "The hardest thing for me was to see her so happy that she could choose to die. Well, for me, it would be so sad to lose her. I had to hold both of these feelings at the same time and be okay with them. I'm now able to do that." And I see that so often, where the loved one is saying, I support my loved one so much, but I don't want them to die. And so it's this very conflicted place to be. And so, I think that that's something as clinicians to keep in mind, again, when we're thinking about bereavement support going forward. In this paper, they also talked about one patient having to be moved from a religious based institution to another institution because the original institution would not permit MAID on the premises. And they said what was horrible was to hear him scream and cry out every single bump. It could have been so beautiful and peaceful if they could have just come into the room there. It could have been that simple and that beautiful, and for us too. And I think that remains a challenge, and perhaps an area where Death with Dignity can continue to advocate for patients as well. And then again, thinking about MAID compared to naturally occurring death, this came up in this paper as well. So MAID was thought to provide some advantages. So many people actually feel very grateful for that opportunity to say goodbye. They feel that the death by MAID is very often quite peaceful. In contrast with, suicide, if someone were to take their own lives, which can often be a lot more difficult and messy and traumatic for the surviving family members. So I think those are all things to keep in mind for sure. This paper just came out earlier this year and is co-authored by one of the members of my PhD supervisory committee, and Bruce. And I think it's quite interesting too. So again, they had some themes that were similar as well. So the certainty of date and time of death. For some people found that helpful, other people found that difficult because they felt like everything was then on a countdown. But at the same time, they had this opportunity to say goodbye to their loved one and, do some last minute things with their loved one that they really enjoyed. And then, I think as healthcare providers, we have to pay attention to this. So family engagement as planners supports sense making. So people were able to kind of make sense of what was going on. Again, there was this notion that not everyone really fully understood what was going to be happening with MAID. So there's an opportunity for us to be better educating family members and loved ones. And also making sure that they don't take on too much in terms of, being the planners and all of that. And then, ceremony was seen as being very important to be able to help people to digest loss. So very often people would have almost like little parties on the day of the procedure. And so, of course, everyone will be very different in how they do this. And as healthcare providers, I think it's up to us to find out what's important to the patient and their loved ones, and then find a way to support that. What's been difficult with COVID is that there have been visitor restrictions that have made it difficult for not everybody to come in to be present. If somebody was, for example, undergoing MAID in hospice, for a period of time, we had limited visitor access in hospice. And I remember doing one assessment at one of the hospices in Calgary, and the patient I saw had, she had a husband and 2 kids, and she was allowed to pick 2 to come to be there on the day of provision. How do you pick between your 2 kids and your husband? And so ultimately she was considering going home for provision, but she was extremely frail, and that was not going to be an easy scenario. So that was challenging for sure. And this is just, a sampling of, or just showing you who the participants were here. And so most of them were within, a year or so, some more recent of the MAID death. And then most of them were supportive of the choice. And again, this is where I think that grief might become a little bit more complicated, is if there's a family member who's not supportive of the decision to undergo MAID. So I think there's still a number of challenges and controversies. Again, I think availability and accessibility of palliative care is still an issue. I don't think that we provide comprehensive enough services for people. When we're talking about what brings people joy, one gentleman I saw was an artist, and all he wanted to do was to be able to paint. And why did we not have an art therapist to be able to come in and help him to do some of that? Music therapists, pet therapists. We don't think kind of outside the box as much as we should, I think, sometimes in healthcare. There will always be this question of, are we doing enough to protect the rights of people with disabilities? And then, as I've already mentioned, the impact of COVID has been difficult. That report that came out from the federal government, what's known about the 16% of people who didn't receive palliative care? Why didn't they receive palliative care? Maybe they didn't need it. Maybe they knew of palliative care, but they just didn't feel they needed it. And that's okay. I saw somebody in April, and she knew of palliative care. She had met with palliative care, but she did not think she would benefit from palliative care and did not want to have palliative care involved. That's definitely her choice. And, that's a piece as well that I'm exquisitely aware of, is that when I'm introducing potential ways to alleviate suffering, it's very important that those ways to alleviate suffering are acceptable to the patient. So when I talk about pain management, and we have many, many medications and different things we can do for pain management, for somebody who maybe has history of addiction, doesn't want to be on an opioid, or for somebody who knows that the amount of medication they're going to need is going to make them drowsy and they won't be able to interact with their family, that maybe is not acceptable to them. And that's okay as well, because it's built into the legislation that the treatments that we offer, they're not required to take them, particularly if the treatments aren't acceptable. And so that's a piece that I think is just so essential and key. Again, this will be an ongoing question. So what are the reasons why patients are considering and following through with MAID? Are there opportunities to improve care? I would suggest yes. I think we need more support for home care, more support for families and caregivers, more support for patients to remain at home as long as they can, if that's what they want. And then definitely rural and remote patients, I think really there's a lack of access to really comprehensive care. And then we've already kind of raised this question that, if anything, it seems like the bereavement outcomes might be a little bit more positive for loved ones after a MAID death. Overall, I think our society doesn't do a great job of bereavement care. We've got some resources, particularly concentrated in many of the urban centers, but very often we don't have that follow-up. And even the palliative care consult service, we send a card out, But I really think that it'd be great if we could have follow-up phone calls, at various different intervals down the road and just check in with people. Yeah, that long-term bereavement support, I think, is really missing. So here again, you'll hear me talk a little bit about protecting people's rights. And so Sean Taggart was a gentleman from BC, from Powell River, who had ALS. He was quite young, and he was looking to stay at home as long as he could. He used this big computer machine, an eye gaze machine, to communicate with other people, to surf the internet, and kept him entertained and also helped him communicate. He was really pushing for 24/7 funded home care, and he was offered very close to that. Ultimately, in the end, about 20 hours a day, he was being supported. But the health region kept pushing him and saying, you should go into institutional care. But for him, that would have meant, being 6 hours away from his son and his support system in Powell River. He was told he wouldn't be able to bring this machine with him. And so ultimately he'd be stuck in a hospital room, staring up at the ceiling all day, with very little, social interaction and mental stimulation. He did elect to undergo MAID. I became friends with him, and I was advocating for him and pushing and writing letters to the BC Ministry of Health and really pushing. But again, I think his case raised the point that we need more supports for people to be able to stay at home as long as they want, if that's what they want. We need to make sure that if people are requesting MAID, they're doing it for reasons that they want. So I definitely think that we can't always alleviate all aspects of suffering. And I definitely think that MAID should be an option for people whose suffering cannot be alleviated. But I don't ever want MAID to be an option because it's more convenient, or because it's cheaper for the government, or because it's easier than trying to manage somebody's complicated symptoms and things like that. So fully supportive, 100% of MAID. But I also want to make sure we don't lose track of supporting patients in ways that I think we still very much need to be supporting them. And you've probably all heard about Roger Foley as well. So allegedly was told that he should consider MAID as an option. He again was looking for more support for home care. And, that was a bit of a struggle for him as well. More recently, and this was in the context of the pandemic now, this gentleman, I can't remember his diagnosis, I have it somewhere. It was a metabolic condition, very young. He elected to undergo MAID, and his family really feels it was because of the horrible conditions in his long-term care facility that he was in, where, there was urine on the floor and garbages were overflowing. And allegedly the family was also very concerned about the type of care he was receiving. And so again, if people are choosing MAID because of reasons like this, that is a concern for sure. If the reason was that his medical condition was progressing and he was having real suffering because of that to me is a perfectly reasonable consideration. And to be fair, even Sean, his ALS was progressing. And we weren't going to be able to fix that. There's no question. The question that will always kind of linger with me, though, is did Sean choose MAID earlier than he would have had he, received the funding for home care? Did he leave too soon? Could he have spent more time with his son if he would have had 24/7 home care? And cost wise, had he elected to go into institutional care, it would have cost at minimum $4,000 a day, and he was looking for about $700 worth of care a day. So sometimes these decisions don't make a lot of sense. And this one was also announced in the news recently as well in the context of the pandemic. And this woman found it very lonely and difficult in lockdown in her retirement home, and so elected to undergo MAID. And clearly she met the criteria for MAID anyway because of her medical conditions and other reasons. But again, did she choose MAID sooner than she would have otherwise because of the conditions in her retirement home and the lockdown in particular that prevented her from seeing family and friends? So these things I think we always need to keep in mind. Definitely, I think that there still are some barriers to the assessment and provision of MAID. And I really think about lack of education for healthcare providers, This study was done out of Toronto, and they invited feedback through phone and email feedback, focus group feedback, and then they had a survey as well. And, there's a lot of different things that the participants felt could be made better. So process clarity for sure. It's confusing, I think, for a lot of people to understand the process, even clinicians, but I can only imagine what it's like for patients and their loved ones. And then changes with the scheduling, the reflection period, I think can be hard. And then clinician judgment and objection. We still see this, unfortunately, very much in healthcare. And then this secrecy and privacy, and then big comments, huge comments about lack of bereavement support. Again, as I mentioned, there have been some changes for sure in the context of COVID, being a little bit more difficult. We were speaking about witnessing, even could this be done virtually? I can tell you that as an assessor, they gave me the option at times to do assessments over the phone or virtually. My preference is always to see people in person, but there was one circumstance where the person they were very concerned she would lose capacity. And so I did do that assessment over the phone. But I think that there definitely have been some barriers and challenges imposed by MAID for sure. One of the questions that came up is, what are the tools and resources for patients and their loved ones after a cancer diagnosis? There are a lot of great resources and tools and supports out there. The Alberta Health Services Cancer Control has a booklet called Newly Diagnosed with Cancer. I can send the links to all these resources as well. I really think Wellspring is a great resource. I've heard tremendous things. I've done talks at Wellspring as well. Again, though, concentrated only in some centers. So Edmonton and Calgary have Wellspring, but some of the rural sites definitely don't have these same kinds of supports. Canadian Cancer Society, of course, has lots of information. They've got a chat support and phone support as well. BC Cancer, and again, I probably shouldn't say this out loud, but I will, but I find BC Cancer, they used to be the BC Cancer Agency, and now they're just BC Cancer. They have fantastic information for patients and loved ones about cancer, about medications and different things. Their website's super, super easy to navigate. I find it a little bit easier than Alberta Health Services for sure. So lots of options there. And then tools available to alleviate suffering at end of life. Here's my bias again coming in. Palliative care. And so historically, palliative care was associated with end of life care and hospice care. But now the World Health Organization definition, which is at least a decade old, is saying palliative care is applicable early in the course of illness in conjunction with other therapies that are intended to prolong life and even cure the underlying disease, such as chemotherapy, radiation, and all these other things. And so it doesn't have to be either or now, active disease-directed therapy or palliative care. We're saying we should be integrating palliative care much earlier. And in the context of cancer, we know that there are multiple different things that can cause suffering. There's physical suffering, psychosocial suffering, spiritual suffering, practical issues, and then, end of life care and death management is one tiny piece of this. And so recognizing that palliative care can really provide this biopsychosocial, spiritual, comprehensive care to people who are facing serious illness or injury. And really there's a push now in the oncology world to integrate palliative care much earlier in the disease trajectory. This is a palliative care doctor from Duke, from North Carolina, Duke University. He's really funny and he does all these cartoons and stuff. So, what does palliative care do? And again, as I mentioned, we've got palliative care consults services in hospitals and the acute care sites. We have outpatient palliative care clinic visits. There's one at Tom Baker and the Cross Cancer Institute. We've got community-based palliative care. We've got rural and remote support here, though it's not as robust as I think it should be. There are rural and remote palliative care teams as well. And then again, historically, we only gave or implemented palliative care when somebody's disease became incurable. And so it was kind of this, we would do all of this disease-directed therapy, and then suddenly the disease is no longer curable. Now we introduce palliative care. But we've switched this now to say that pain and symptom management, palliative care should be integrated from time of diagnosis, and then it just changes to how and is tailored to the needs of the individual person as to how much palliative care they need. We know that if we integrate palliative care early on in the disease trajectory, we have better symptom management, we have improved quality of life, we have better understanding of the disease itself and prognosis, we have better caregiver outcomes in terms of quality of life, better mood, reduced anxiety, depression. We also know that people tend to use ICUs and things like that less, and hospice more if they have palliative care involved. And overall impacts on resource utilization. And some studies have also shown that if we integrate palliative care early, there is a survival benefit. And that was first shown in 2010 in a study that looked at people with advanced lung cancer and compared early integration of palliative care to people who are getting chemo. They actually found that the people getting palliative care had better survival. And we also know, again, that caregivers' support needs are really significant and often very prolonged and persistent, and integrating palliative care can really help to improve caregiver quality of life and outcomes as well. If we don't have palliative care, or if we integrate it late in the disease trajectory, we see underuse of hospice, underuse of family caregiver support, less comprehensive pain and symptom management, and we don't see those conversations about goals, values, and wishes happening so much. We see potential overuse of these things. So life-sustaining therapies, chemotherapy and radiation therapy in the last weeks of life, ICU admissions, emergency room admissions, feeding tubes, and all kinds of things that we often find out after the fact are things that the patient would never have wanted anyway. Importantly, I think sometimes what we do when we don't have these conversations early on is we end up putting the patient in a situation where their remaining time is spent in hospital, attending appointments, feeling lousy because of side effects, where they could have taken that time and really enjoyed that time and good quality with their loved ones. There are many barriers to the integration of palliative care. I think there's still this huge stigma about what palliative care is, and this reluctance to acknowledge that somebody might be dying. A lot of clinicians perceive that as failure on their part, that they were not able to cure the person. There's lack of training as well, as I've mentioned. And then I think there's still this huge confusion about what palliative care is. And there often can be discordance in the family about the direction or focus of care. And then I think as well, very often people do not understand what the intent of the treatments are that we're providing, and they often overestimate the benefits of the treatments that we provide. And what they're giving up for that, again, is potentially quality time. There are a lot of system barriers as well. We don't have, now we kind of have a national framework, but not a lot of action yet on that national framework. We know that there is a lack of palliative care providers, especially in rural and remote areas. COVID's taught us, though, that we're able to provide a lot of care and support virtually. And so now there's no reason why we shouldn't be able to at least have some telehealth or video health support for people in rural areas. And so again, back to this importance of palliative care involvement, this patient I'd seen back in March, she was a physician, also had a PhD, very active, climbed mountains, just extremely bright and very, energetic, in spite of being 82 years old. She did not look 82. And she had a new diagnosis of metastatic pancreatic cancer, underwent a major surgery back in January. She knew from the get-go, she did not want chemo, did not want any other disease-directed therapy. She knew her prognosis, and she just wanted quality time. So she put a MAID request in, and I went to see her, and her main reason for requesting MAID was that she was having severe pain. Well, she just had this surgery, and they were still packing the wound. The wound had become infected, it was open, and they were doing dressing changes all the time, which was very painful. She only had Tylenol as a pain medication. And so that blew my mind. But again, highlighting some gaps in care in our system for sure. And so her family doctor wasn't comfortable prescribing opioids, and the surgeon had discharged her. So she was kind of in this no man's land. And so I undertook to prescribe some sufficient, I would say, pain medication for her, an opioid. And now, she's now still with us, and pain is not an issue. And she's the person who's now twice rescinded her request to undergo MAID, even though the date had come up. Her quality of life is much, much better. So again, this would have been, to me, very unfortunate had she undergone MAID. It would have been a missed opportunity here for us to intervene and ensure that her quality of life was as good as it could be. And the impact on her family, I think, would also have been significant. And so now they know, she still has the MAID request in, and she still knows she can request provision at any point. And that, I think, is a little bit of insurance, and she's happy to have that option. But for now, she's just going day by day. We know this again, and I realize I'm getting close to the end of my time blabbing here, so I'll be very quick here, but that the ranking of palliative care across the world, Canada ranked beneath a lot of other countries. You can see we ranked 11th overall. Part of that was because we don't have a national framework on palliative care, or didn't at the time. But a lot of the other metrics they used to assess this, we didn't do that well. We were not doing that well comparatively. So definitely there's a lot that we could be doing better. And that this report, the Canadian Institute's Health Information came out with this in 2018 and highlighted that a lot of issues in terms of access. So, 15%, only 15% of Canadians were able to access palliative home care, in spite of the majority saying that they wish to die at home. So there's an acknowledgement, at least, I guess, at the federal level, that there are some deficiencies in the system for sure. Again, we know vulnerable populations as well. And I would say in terms of accessing both palliative care, but also in terms of accessing MAID. So how to do homeless people, access MAID? How do they access palliative care? We know that there definitely are some issues in terms of accessing either. I think there's a huge intersection. This was another question posed. I think there's a huge intersection between MAID and palliative care. I don't see them as being exclusive, mutually exclusive. I don't see them as being opposing. I see them as being, really interrelated. And I think, definitely we want to make sure that there is adequate palliative care, both available and accessible to people. And again, I'm saying that if suffering cannot be relieved, I really believe that MAID should be an option and part of the toolbox that we use to help alleviate suffering. My hope would be that, a very few number of people would need to undergo MAID. But I think that we cannot delude ourselves in thinking that all suffering can be relieved. And not all suffering can be relieved to measures or with measures or in ways that's acceptable to the patient. How to have difficult conversations. I think that the onus on this should be on healthcare providers, should not be on patients for this. And definitely this is something that's being integrated more in medical and nursing school curricula, that we need to be better at this, in terms of sexual health, in terms of talking about death and dying. It's very often the clinician who's uncomfortable initiating these discussions because they don't want to make the patient uncomfortable. But by doing that, we make them extremely uncomfortable and don't provide them with critical information they need to know. So if we don't raise it, it either means to the patient potentially that we don't think it's important, or it's not an issue, and that further leads to patients not wanting to talk about it or bring it up. So I would say don't ever hesitate. You have a right as a patient. Definitely make sure your concerns are being addressed, and if you make the clinician uncomfortable, that's on them. But having these difficult conversations, I think, you need sufficient time. I always say to people, write stuff down, because I tend to forget important things when I go into appointments. Bring a family or family member or friend, volunteer. You can ask the clinician if they're okay with you recording the conversation. I think sometimes it's very difficult in the heat of the moment to remember content, and recording it can be very helpful. If language is a barrier, bring an interpreter, use the language line that's available at AHS facilities, and then always being very clear about what's important and what your goals are. The Advanced Care Planning Canada has got some great conversation starters and some examples of conversation starters to help introduce some of these difficult topics. These are more pertaining to end of life and advanced care planning kinds of topics. And to quickly talk about Maiden palliative sedation, because I think this is such an excellent question. And this was something that I've always had huge interest in. I wrote a paper about this in 2019 with one of my profs at the time, looking at the similarities and differences between MAID and palliative sedation. And I think the general public doesn't know about palliative sedation. So again, when I do assessments for MAID eligibility, I talk about palliative sedation as well. I let them know this is an option. It's not something that the general public knows much about. Again, it needs to be acceptable to the person. So one of the downsides of palliative sedation potentially is when we sedate somebody, usually the intent is that we're going to sedate them until they pass away. So this is usually done within a few days of the anticipated death. So again, that's tricky because we have to be able to kind of predict if they're on a significant downward trajectory. And there have been definitely some cases where in the literature where palliative sedation has been reported to occur, for weeks. When somebody is sedated to the point that we do in palliative sedation, they're not capable anymore of eating or drinking on their own. And so usually if they're sedated to that depth, they're not able to, they're going to, if they're not able to eat or drink, then we can predict that the time is quite short. And so that has come up in the literature as well, as a difference. Philosophically, personally, I don't see huge differences between the two. I think, the intent with both is to alleviate suffering. Hastening death with MAID, I guess you do, but, potentially you also do with palliative sedation, because again, that person's not able to eat or drink anymore. Level of consciousness. Now, this is interesting too. So, again, some people don't want to be unconscious before they die. They would rather be awake, conversing with their family members and loved ones. So MAID might be a little bit more appealing in that sense, because with palliative sedation, they will not be able to engage in any kind of conversation with their loved ones anymore. The impact on family, I think, both ways. If we're providing a more peaceful, exit, so to speak, then I think the impact on family would be positive for the most part. I think there's some overlap here. So the doctrine of double effect, the action that we're undertaking, is it, causing another unintended action? And if so, then that's fine. So people who say that palliative sedation is different than MAID would say that, palliative sedation, you're not intending to kill the person, you're intending to relieve their suffering. But I would say that's the same for MAID as well. Then we're not intending to kill the person, we're intending to relieve their suffering. This is the only way that we can do it, because we've explored all the other ways. Reversibility, I would argue too that might be an area of overlap. So people will say, well, you can reverse palliative sedation. But if you look at the true definition of palliative sedation, when we start palliative sedation, we don't ever intend to reverse it. The only time that would happen would be if the patient directed us to reverse it. So we don't intend to reverse it. So it doesn't make it that different than from MAID. And, theoretically, you could reverse MAID within minutes. Again, we wouldn't do that. We'd be clear about the intention of that from the get-go. And then the differences. So the indications, again, palliative sedation, we can do palliative sedation virtually on anybody. We don't have legislation around palliative sedation. We don't have criteria. There's really nothing that limits our ability to provide palliative sedation to somebody. The consent piece worries me a little bit, because clinicians could elect to start palliative sedation. Family members could request that we start palliative sedation on somebody, and we do not need consent. So Alberta Health Services guidelines on palliative sedation say that we should get consent where possible, but that's not always possible. So that piece to me is a little concerning. Proportionality, I think, again, people say that palliative sedation is different because you're only titrating the palliative sedation. So you're only adjusting the sedation level to the point where you're alleviating the person's symptoms. Well, I would say the same is true with MAID. You're titrating or adjusting your medications to the level you need to alleviate their suffering. The outcome in that circumstance is that they die. But the outcome with palliative sedation is very often that they die. And so I see these two procedures as being very similar. And again, we know historically that the recommendation is that palliative sedation should occur only in consultation with palliative care specialists and in certain centers. It can happen in hospices. Theoretically, we can also provide palliative sedation at home. It's a little bit more difficult, but there should be consultation with palliative care teams before starting palliative sedation. Does that happen in real life? No, and there's reports from other jurisdictions in other parts of the world that, there's this kind of creep, I forget what they called it, where this is happening in other types of settings where perhaps the clinicians are not appropriately educated or prepared to provide palliative sedation. And again, the worry would be here that if you have somebody who's got very complex symptoms, is it easier to sedate them than to try and manage their symptoms? Is it cheaper to sedate them than to try to manage their symptoms? And so again, I have the same concerns I would have with MAID, that we really need to make sure that the experts that ought to be there are there, and that we are not missing something and we're not taking an easier way out, that we're still making sure that we're doing all we can to alleviate suffering in ways that are acceptable to the patient. So NPs, as you know, nurse practitioners can assess and provide MAID. I think all nurses should be able to listen to patients' requests for MAID. I think they should understand what's underlying the reason for the request, what their fears, worries, concerns are, what their goals are. We have an obligation as nurses to be able to help the patient if they put a request forth. So there's the conscientious objection. People can say that they don't want to be involved in the provision of MAID or the assessment, and that's fine. But patients still have the right to have that information. They still have the right to access MAID and undergo provision if they qualify in a timely way.
Reanne, someone submitted a question about this slide.
Yeah.
They're wondering kind of what are the numbers of nurse practitioners who are actually participating in Alberta in the MAID process?
Yeah, I don't know that for sure. It's interesting because again, a lot of this is hush hush. But I do know that there is another one in Calgary who does assessments and provision. So it'd be interesting. I know I haven't seen the Alberta Health Services MAID Care team release this data. I don't know how many, I know the MAID Care team main contact people, that changes somewhat regularly, but I don't know how many, they keep that information protected. It'd be nice if they just gave us an overall number of how many physicians and how many nurse practitioners are involved, but I don't know that. They've protected that information, I think, again, partly because of the potential stigma associated with that information. So it's a good question. And I do think that all nurses really need to support patients and families pre, during, and post MAID. So if they don't want to be there during the process, the provision itself, I mean, they still need to support patients throughout the process. We don't choose. I don't think, this is again my personal belief, I don't think we can choose what kinds of care to be involved with. We have to think of what's best for the patient. So the challenges I've had, for sure, difficulty with capacity, that's always been a challenge. There's only been one patient I've been involved with where I determined that he didn't have capacity to consent and his family agreed. And so that was difficult. And then of course, as I've already mentioned, the visitor restrictions imposed by COVID have been very challenging. One comment just about the Oasis Clinic, that is the Oncology and Sexuality Survivorship and Intimacy, well, I mixed it up, Oncology and Sexuality, Intimacy and Survivorship program. There's an Oasis salon in Calgary that a lot of patients thought that we were calling from a salon. And there's also an Oasis clinic in Cochrane as well, but it's a primary care clinic. So this was a clinic, and the clinic's still operating, to my knowledge, at the Cross in Edmonton. Our clinic in Calgary is no longer operating, but we do have a physician who will take referrals. And this clinic and program offers support for sexual health concerns, which are very, very common after a diagnosis of cancer and many other types of illnesses as well. And so physically, I would do physical exams on patients, order any lab tests and things like that, sometimes do biopsies, and then where appropriate, intervene with different interventions. A lot of times it was just education. Sometimes I did prescribe testosterone treatments to some men. I taught men how to inject medication into their penis to lead to pretty instant erection for people who had challenges with erectile difficulty after cancer treatment. Sometimes it was using medications like Cialis, Levitra, and Viagra. So yeah, it was really, again, our approach was very biopsychosocial. And so we had, in this picture, you can see it's myself, a nurse. We had a couple of psychologists involved in our program, and a psychology fellow and student were involved. So really tackling this from a biopsychosocial perspective. So we had, if it was a couple, we'd have both members come in if they were comfortable doing that, and really address things holistically. So I believe, again, this clinic is still operating at the Cross, and in Calgary, we have some resources and services available. It's just a little bit different in terms of the delivery. And yeah, I left this blank intentionally because now I'm hoping we can have some conversation. I mentioned already to Brad that I go to the Death with Dignity Canada site a lot because it's updated often more regularly than Alberta Health Services websites are. And I see a huge role here. So one thing especially is the concern about people having to be moved off site of religious affiliation, or religious affiliated institutions, hospices, and care homes and things like that, that will always be, I think, until it changes, that will be an issue. I don't think it's appropriate to be moving people at end of life right before they undergo MAID. I think that's very unfair to them and can be very logistically difficult. A lot of people won't take their pain meds. Again, now we've moved that, that's been removed, that final consent, because we did see people who wouldn't take their pain meds because of fear of being determined and unable to provide consent due to capacity issues. I've seen that too, where people, when I go to see them, they don't take their pain meds because they don't want me to determine they don't have capacity when I do the assessment. And that, I always try to educate them that that's not an issue at all. I won't determine them to be, incapable of consenting. And I tell them to take their pain medications right away because I don't like to see people in pain, but I still see there being a huge role, and definitely another area would be ongoing education about death and dying in general, but also about MAID and what the steps are, how to access it, what it looks like, and if there are family members who can provide support to other family members and do some of that peer support as well. I think that would be a huge potential role.
That's amazing. This has been so much good information. Thank you so much. The question about the role for organizations like ours, especially around the awareness issue, I think is something that locally we are really focused on. And prior to COVID, we were presenting at a lot of other organizations' meetings to try and raise awareness, because I think there are still people who don't realize that MAID is actually available, that it is legal now. We did have one comment come in that said, when we look at the rates of MAID in Canada, how do we factor in awareness as we see the numbers increasing? And so do you anticipate that those numbers will plateau at some point when awareness kind of matches the ability to meet the needs of patients?
Yeah, I think other jurisdictions, they've certainly seen that plateauing. I think though concurrently, we need to look at what else is happening with end-of-life care in our country. And my fear, my worry is that those numbers will continue to rise until we do something more about improving end-of-life care. And I think, things are not, they haven't been getting better. I'm a bit hopeful with the framework and now the CPAC's involvement in producing that framework about educating different disciplines. I think that's really important. But yeah, other jurisdictions, they did see a plateauing. So it's possible we will see that at some point. But I also agree the awareness piece is still not there. And a couple of years ago, had a family member who was dying of metastatic breast cancer. And after she died, her son was mad as could be with me. He'd been living in Ecuador and did not realize that MAID was an option. And he tore a strip off me and said, "You did not tell my mom about this." And I know she and I had many discussions about it, and she did not want MAID. Unfortunately, she had a terrible death with unmanaged symptoms in spite of being in a hospice. As it turned out, there was a shortage of the medication being used. They were using to sedate her. It was awful. And so he was really mad, and his experience of her death, unfortunately, was very negative. But that also raises another issue. As a clinician, I'm not permitted to bring MAID up first with a patient. If they bring it up, and this has been debated, so Jocelyn Downey, who many of you I'm sure know, I believe she's from Dalhousie, she's a lawyer, and she's a proponent of healthcare providers raising MAID as an option. It's a legal option in Canada, so why shouldn't we be allowed to raise it? The flip side of that is that healthcare providers are in a position of power over patients because of the vulnerability of patients. And so if I bring MAID up, would my patient potentially think that I am suggesting they should undergo MAID as a viable or better option than the others? But if I bring MAID up as an option, in a list of other options, so I'm not just bringing it up on its own saying, out of the blue one day, oh, have you thought about MAID? But hey, here's a list of all the things that might be helpful going forward in terms of alleviating your suffering, X, Y, Z, and list them all. Then to me, that doesn't, it's not really kind of the same context as bringing it up on its own. So I think how we bring it up is probably important. But should we be, should we not be allowed to bring it up at all? I don't know that I agree with that. And I know each nursing association in Alberta is a bit different in terms of what they say nurses are allowed to do. And so it's definitely an area of some controversy, but if patients aren't aware of it, and again, if we've got patients who are homeless who don't have access to, a lot of the other sources of information for these kinds of things, is it really fair to them if they don't know about MAID as an option?
I think that's a very, very main problem, especially so for here in Edmonton, where 90% of our palliative care beds are with Covenant Health.
Yeah.
It's bad enough that people have to be transferred, but what's even worse than that is Covenant Health doesn't do anything about educating people, letting them know about MAID. We've had discussions, our Calgary and Edmonton group, with the Covenant Health group that has the grant from the province on palliative care and end-of-life care. And we've had one meeting with them, and they absolutely refused to agree that MAID should be a part of an end-of-life discussion, end-of-life care, and it's just mind-boggling.
Yeah, and there's pushback legally, I think, and I don't know where it's at. Again, I think Jocelyn Downey has spoken to this as well, that if an institution is receiving publicly funded dollars, that should they be permitted to operate in a way that is not in accordance with a legally permissible option. So I'm surprised that they've still taken that stance. It would not be acceptable if somebody in their facility said, oh, I don't agree with the use of opioids. We shouldn't give any opioids as painkillers to any of the patients in our Covenant Health facilities. It just doesn't go with my beliefs. That would be unacceptable and ludicrous, and it would not fly. There's just, again, there's that stigma with MAID. And it boggles my mind that they've dug their heels in on that.
In your stats on Alberta, in terms of people turned down, I noticed that Alberta had the highest percentage. We were 11% of people who were declined, and most of the others were like 4 or 6%.
Yeah.
Is that a significant thing? And are we more whatever in terms of turning down more? I wonder why that would be.
Yeah, it's a good question. And, the report does go into a little bit more detail about some of that. I was just going to consult the notes here and see if they said, I don't think they provided more information about that, the reasons why, but you're right. Alberta was high. They didn't have data from all the other provinces. They only had from Quebec, it was 9.5%, Ontario 5.4%, and BC 9.7%, national average 7.8%. And yeah, 11% of requests in Alberta had been declined. And I don't know the individual reasons for that. That'd be very interesting if they could provide more context for that. Maybe some of that is, I'm not sure if it has something to do with the institutions that they're in. And there's still so much subjectivity with MAID assessments. And so, how do you determine? To me, it's so much driven by the patient. I always felt it weird to go in and assess somebody, and determine, do they have a condition that's causing irremediable and grievous suffering? Well, if they tell me they do, I think they do. So, and then again, the flip of that is, are they, are treatments available that they should be undertaking? Have they pursued all of that? I've heard that before from people too. Well, those treatments have to be acceptable to that person. And so, yeah, I'd be curious to know more about that as well, what the reasons were.
I'll try to squeeze in just maybe 2 more questions here. We're almost at 8 o'clock. but some great questions coming in. I apologize if we can't answer all of them, but Reanne did include her contact information. So if I don't get to your question and you still want to follow up with her, I encourage you to do that. Someone wrote in asking about the role for death doulas in the end of life process, and if you have any thoughts about that.
Yeah, I've heard about that. And I think, we use doulas for birth and, the whole experience of dying. We don't have a lot of supports, I think, education for people. So yeah, I think it's interesting. I don't know what their training would be, but I think that it's definitely an interesting concept. So I haven't had any personal experience with it, but I do think it's interesting for sure.
And when you're doing your assessments, someone asked, how exactly are you determining which track they fit on in terms of reasonably foreseeable or not? Can you give us a little insight into that?
Yeah, so, for me, I'll give you another example of somebody who had pancreatic cancer. To me, metastatic pancreatic cancer. And again, because my background is oncology, that for me was very easy. So similarly, certain types of metastatic disease, prognostically, I can kind of predict what things might look like. But that particular patient, I determined the death was reasonably foreseeable. The other assessor determined the death was not reasonably foreseeable on the basis of the majority of the bulky pancreatic cancer having been surgically resected. But I looked at the pathology report and saw that the surgical margins were positive and there were lymph nodes that were positive. So at the time, this patient didn't have detectable pancreatic cancer necessarily in the body, but it was only a matter of time before the disease recurred. So again, you can see how subjective this is. And how important it is, I think, to have somebody who understands a little bit about the underlying conditions. I had another one recently that I thought was very difficult because she had a number of comorbid conditions, many of which were incurable, but probably not imminently life-threatening. But again, if she was to choose to stop taking any of her medications that she was using to treat those conditions, then again, to me, her death becomes very reasonably foreseeable. And again, that was a case where I might have involved, the expertise of other people who knew more about those individual conditions. But then, so I saw her initially back in April. She withdrew her request at that time. And then they asked me for a reassessment just a couple of weeks ago. And they said I could just do the assessment based on my previous one. I elected to go see her in person, and I could see her breathing had changed significantly. They told me that she was spending most of her time now in her bed. She was not eating as much. These are all things to me that say things are reasonably foreseeable. And ultimately, she ended up dying that afternoon. But on paper, her death would not have looked reasonably foreseeable. So I think this assessment piece is really key. And it's the totality, the holistic nature of that assessment. So, physically, emotionally, psychosocially, what's happening with the person, what's been happening in the preceding months, what's the trajectory of their functioning. It's this huge big picture. And with that exception, had I just gone by paper, I probably would have said her death is not reasonably foreseeable, but I would have elected to bring in a specialist to help make that determination. So I think we really, as assessors, ought to be very careful if we're determining that somebody's death is not reasonably foreseeable. We need to really have clear reasons for that and a clear picture of what to do going forward with that. And, the 90 days, they'll still ultimately potentially undergo MAID. There's just that 90-day period then that's different, which for somebody who has grievous and irremediable suffering, that 90 days seems pretty harsh. But again, for me, if I was to make that determination, I'd want to have some really good reasons behind it.
I think maybe we'll wrap up there, but this has honestly been so great, and I feel like we could chat with you for a long time. Thank you for putting those slides together and addressing so many of those really interesting topics. I'm so fascinated by your work on palliative sedation. I wish I had kind of known about this before. It would have helped so many of my conversations in the past. And thank you for all the work you do as an assessor and as a nurse practitioner. Do you want to throw up that slide that had your contact info just as we kind of close out the webinar? Do you mind doing that once more?
Yeah, for sure. And,
Okay.
you know, I'm looking at some of the comments that people have made and I won't name names, but yeah, so watching somebody with palliative sedation. So again, that requires, in my opinion, a really careful assessment of who is going to benefit from palliative sedation, because not everybody necessarily will. And if that dying process, and this comment is that for 3 days she died, stopped breathing at least 100 times, it was agony. Yes, I can only imagine. And I'm really sorry that that was the experience, because that is not how it should be. And again, that may not have been the most appropriate option, or the sedation might not have been titrated appropriately. It's really hard to know for sure what might have happened. But I would just say that, you know, I'm really sorry for that experience. And Brad, is there some way, I'm going to try and copy all these questions if I can, and
Sure.
and then I can email answers to you that you could send out to the group, maybe, if that's okay. And then the other thing I was going to say is I'm happy to send any papers or articles too. So if people have requests for any of those, please send them to Brad, and then I can pass things on.
Great. I just copied all the remaining questions into my spreadsheet here, so I can share those with you afterward. And I'll just remind folks about, again, the summer webinar series that National Office is hosting. So I encourage you to sign up for those if you found this conversation interesting, just more conversations like this through the National Office. And of course, the local chapters will continue to host sessions like this. So keep an eye on your email, and probably in a couple months, we'll bring forward another speaker or presentation, and feel free to contact us and suggest ideas for topics as well. So again, I just want to thank you so much, Reanne, and wish you the best of luck with your PhD research. And I hope you'll continue the great work that you're doing.
Well, thank you so much. And I'm just going to squeeze one more last thing in here too, because I didn't cover it, but as of right now, the legislation doesn't permit us to put that we would prefer to have made. We can't put that into our personal directives. Well, it wouldn't be legal necessarily for someone to follow through with that at this time, but I did put it in my personal directive, and I worded it in such a way that said, you know, if at the time of my condition changing or you know, some event happening, these are the circumstances where I would wish to consider MAID, should it be permissible at that time to have it put forth in a personal directive in advance. And I was very specific about what I would determine to be not good quality of life. And I gave some, you know, some very concrete examples. And I also made sure that my agent is very aware of that as well. So it's not legal yet to follow through with the MAID request that's been put into a personal directive, but I see a comment about dementia. And so thinking about that or other circumstances, and again, just being as clear as I could be, I did put that in, and I had a lawyer who went over it with me, and he actually has been getting a lot of questions about that as well. And it was his advice that it was fine to have that in there. Whether or not it will ever be recognized legally, we don't know yet, but I did put it in there. So thanks again, everyone. I really appreciate the opportunity, and please feel free to email with questions or comments. And thanks so much for having me, and hopefully I'll get to meet with your group again.
Yeah, great. Thanks so much. Okay, I'll go ahead and end the webinar now. Thank you everyone as well for attending. We hope to see you at the next one. Okay, goodbye everyone. Goodbye, Carl.
Bye-bye.